All right, guys, I'm going to resume the recording. All right. So our first case here is a 69-year-old man who reports severe left hip and groin pain, followed by leg weakness without any precipitating injury. Manual muscle testing scores are as follows. Okay, so I'm gonna change the camera. Can you guys see her legs? I don't have a chair high enough. Oh, yes, the bar stools. Use the bar stools. Get a bar stool. I'm trying to get her high enough so you guys can see her legs. Because we're gonna do a muscle exam. Now that I want to make sure you guys know. Let's see. Can you guys see her legs? Yes?
Yes.
Okay, good. All right. I'm gonna push you back a little bit. All right. So we're looking at her iliopsoas. Her iliopsoas is that hip muscle. Okay. First thing, before I even go there, when you're dealing with lumbar spine patients, when they come into the emergency room and they're complaining of back pain radiating to the leg, when their pain is radiating to the leg, we call that radiculopathy. So they come in with back pain with lumbar radiculopathy. Oh my God, I can't speak anymore. Radiculopathy, you gotta look right leg or left leg. I want you to do me one favor. Take your hand, spread your fingers, and put it just on your thigh, okay? Right on your thigh. Make sure you guys see my hand? Everybody should be able to see my hand. Answer, because I can't, Dr. Albujar is not there. You guys can see my hands?
No, yes. No, I'm here. I'm here.
Okay, good. All right. See, my thumb is pointing to my groin, okay? My index finger is pointing to my inner leg. My middle finger is pointing down the middle of my leg. My ring finger is pointing medial-lateral, not completely lateral, but medial-lateral. And then my little finger is lateral, okay? And then I have no more fingers. So I want you to get this. This is L1 going to the groin. So if they come in complaining of back pain radiating to the groin, getting to the inner thigh, L2. You can go to the groin and inner thigh, okay? L2. They come in with back pain radiating the medial leg, stopping just below the, above the knee, probably L3. L4 is usually medial lateral, and it goes down to the knee area, okay? Sometimes it can go on the top of the shin. That's L4. L5 is gonna be lateral. It's gonna come down lateral, the lateral thigh, it's gonna come all the way down the calf, and it's gonna go to the top of the foot, the dorsal aspect of the foot. And most times it goes into that great toe, okay? Then I have no more fingers. S1 goes down the back, all the way down the posterior aspect of the leg to the lateral aspect of the foot, into the pinky. Okay? Did everybody get that? Everybody got that? No need for more demonstration?
Can you do that one more time, please?
Sure. Take your hand, spread it across your thigh. Okay? The thumb points to the groin. That is L1. The index finger points to the inner thigh. That is L2. L3 comes down, medial thigh. Usually stops on the thigh. That's L3. L4 comes down the medial lateral thigh. It comes down to the knee. Usually stops at the knee. Can go a little bit into the shin, but usually stops at the knee. L5, you're gonna take your pinky finger. It's gonna come lateral. So it goes down the lateral thigh, all the way down, and it goes to the dorsum of the foot into the big toe. on the top of the foot into the big toe. That's L5. And then S1, I have no more fingers. So if it goes from the back down the posterior aspect of the leg into the lateral foot, into the pinky toe, that is S1. Okay, guys? Dr. Abuha, are we good on that?
Yes,
Yeah.
we're perfect. And
Okay.
Gwendolyn, can you please turn off your video? Thanks.
All right. So now, your iliopsoas. The iliopsoas muscle is the hip muscle, okay? And that hip muscle is innervated by L3, okay? L3, L4. Your quadricep muscle is the top of the thigh, okay? And that's usually L3, L4 distribution of pain. The hamstring is the back, and that's usually S1. The anterior tibialis is basically dorsiflexion of the foot, so you pull the foot back. That is the tibialis anterior. I don't have it here, but I have it in the other one. Extensor hallucis longus is the big toe. So I'm going to tell the patient to pull the big toe back. Pull your big toe back to me. Don't let me pull it. Don't let me push it forward. That's the extensor hallucis longus. That is L5. Okay. Anterior tibialis, pull your toe, your foot back. Dorsiflexion, that is L5. Okay. Plantar flexion, bend the foot down. That's the gastrocnemius, and that is S1. Okay. So if someone comes in, I'm going to test the iliopsoas. I don't know if you guys can see her leg. Iliopsoas muscle, I'm going to tell you, push up on my hand. Push up on my hand with your leg bent. That's testing her iliopsoas muscle. Straighten your leg out for me. Don't let me bend it. That's testing her quadriceps. Bend your knee for me. Don't let me straighten it. That's testing her hamstring. Okay? Lift your leg up. Pull your foot backwards. Don't let me push it forward. That's checking your anterior tibialis. Pull your big toe back. Don't. That's extensor longus. And push your foot down on my hand. That's checking her gastrocnemius. All right? Did everybody get that? Laura? Yeah, we're good?
I'm getting a couple yeses. I don't know if anyone wants it to be repeated. Anyone want it repeated? No, they got it.
Okay, good.
Oh, wait, no. Someone says, please repeat it.
Okay. Okay. Push up on my hand. That's iliopsoas. Okay? And that's checking L3, L4. Straighten your leg for me. Don't let me bend it.
Can you
That's
fix
checking
the camera?
quadricep. That's around L4. Okay? Bend your leg for me. Don't let me straighten it. That's checking hamstring.
Good morning. Can you fix the camera?
Can you see the
Oh, I'm sorry. I'm sorry. Can you see now? Yes?
Yes.
Okay. Let me do it over. Push up on my hand. That's checking her iliopsoas muscle. Her iliopsoas muscle is innervated by L3, L4. Okay? Straighten your leg for me. Don't let me bend it. That's checking her quadricep. Because the quadricep is what's going to keep her leg straight for me. And that's about L4. Bend your knee for me. I'm going to tell her to keep her leg bent. Don't let me straighten it. Pulling on it. That's her hamstring. That's S1. Okay? Put your leg out. Pull your foot back. Don't let me push it forward. That's tibialis anterior, dorsiflexion, and that's L5. Okay? Push down on my hand. That's gastrocnemius, and that's S1. Pull your big toe back. Don't let me push it up. That's extensor hallucis longus, and that's also L5. Okay? Are we good now? You're dying to move out of my chair, so.
Yes, that's good.
Okay.
Thank you.
All right, you can go. She was dying for that to be over. All right. 69-year-old male reports severe left hip pain, groin pain, followed by left leg weakness without precipitating injury. Manual muscle testing shows scores. Iliopsoas is 3 out of 5. Quadricep is 3 out of 5. Hamstring is 5 out of 5. Anterior tibialis is 5 out of 5. Gastrocnemius is 5 out of 5 on the left. On the right, all muscle groups are 5 out of 5. Which nerve groups do you think is being affected by this herniation or stenosis?
L3 and L4?
Yes. Definitely, it's an L3, L4 disc, likely compressing the L3 or L4 nerve group. Okay. Are we okay with that? Reflex exam. Oh God, I forgot I had this on there. Bicep is +2. Everything is +2, so reflexes are not impacted. So we're good. Okay. Your knee jerk, the patellar reflex is L4. Your bicep reflex is upper, so that's C6. Tricep C7, C8. Ankle jerk is S1. So when we're looking at the legs, we're looking at patella, which is L4, and ankle jerk, which is S1. Does anybody need me to demonstrate the reflexes, or you're good with that? Okay, no comments? All right.
Yeah, someone asked me, what about the brachioradialis?
Brachioradialis is about C8 to T1. Okay. What's the most sensitive diagnostic test to evaluate this disc? Remember, tissue, MRI, bone, CAT scan. So if we're looking for a fracture, we can do an X-ray or CT. If we're looking for a disc herniation, which is tissue, we're looking at an MRI. Thomas, a 37-year-old man, proposed to the emergency department with complaint of intractable low back pain with radiation down his right leg. He describes the pain as electric. It starts in his lower back and moves down the posterior aspect of his leg and radiates to the lateral aspect of his foot, including his last toe. He rates the pain at 10 out of 10 on the pain scale. He reports numbness in the lateral aspect of his foot. You examine him. On an exam, you note that patient's awake alert oriented times 4. His cranial nerve exams are normal. Cerebellar testing is normal. His motor exam is below. He has iliopsoas bilaterally, 5 out of 5. Quadricep bilaterally, a 5 out of 5. Hamstring on the left is 5 out of 5. On the right is 3 out of 5. Anterior tibialis on the left is 5 out of 5. Anterior tibialis on the right is 5 out of 5. Gastrocnemius on the left is 5 out of 5. Gastrocnemius on the right is 3 out of 5. Which nerve roots are being affected?
S1?
Yep, S1, for sure. Let's look at the reflexes. The reflexes, his right ankle jerk, which we said is consistent with S1, is absent. Now tell me, why is his ankle jerk going to be absent instead of hyperreflexic? Any takers?
Some
Is
says
it upper
it's
motor
the lower,
neuron disease or lower motor neuron disease?
lower
It's a
motor
lower-
neuron.
Lower motor neuron.
Okay, so it's the lower motor neuron. Remember, upper motor neuron with brain and the spinal cord. Lower motor neuron would be your spinal nerves, your peripheral nerves. So lower motor neuron disease flaccidity, upper motor neuron disease, spasticity, and rigidity. Great job, guys. All right, we answered that already. Gonna have to move this around again. 47-year-old male who reports to the ED complaining of intractable low back pain with radiation down the lateral aspect of his left leg. He describes the pain as electric. It starts in his lower back and then moves down the lateral aspect of his leg and radiates into the dorsal aspect of his foot and shoots into his big toe. He rates the pain as 10 out of 10 on the pain scale. He reports numbness in the dorsum of his foot. You examine him, and on exam, you note that he's ANO times 4. He has normal cranial nerve. Cerebellar testing is also normal, and his motor exam is below. Bilateral iliopsoas 5, quadriceps are 5, hamstrings are 5, anterior tibialis is 5 on the left and 3 on the right. EHL is 5 on the left, 3 on the right, and gastrocnemius is 5 bilaterally. Which nerve root? Here's your cerebral.
Everyone's saying L5.
Exactly. This is definitely L5 nerve root. Looking at everything that's affected, it's a lateral spread of the pain, lateral nerve root compression with the numbness in the lateral aspect of the foot and the dorsum of the foot. That lateral aspect of the leg, and dorsum aspect of the foot is all indicative of L5. Okay. All right. We're almost there, guys. I'm sorry. This is longer than I thought it was. Julie? Jewel? I need you one more time, please. I'm sorry, guys. We got to do the cervical spine. Jenny is a 45-year-old female who presents to the clinic with intractable pain in her cervical area that radiates down her right arm. She reports the pain in the lower part of her neck and radiates to the bicep, down into the lateral aspect of her right forearm, into her thumb on that hand. The pain has been present for 2 weeks. It starts on moving. It started one morning when she woke up. She thought that maybe she slept wrong, but has not gone away. In fact, she believes that it has gotten worse. She also notes that her thumb has been numb for the past 3 days. She describes the pain as shooting, sometimes aching. She's ANO times 3, CNS cranial nerve exam is intact, and her motor and reflex exam is below. I saw a comment come up. Does somebody have a question? Laura, does somebody have a question?
No, they were just all saying C6.
Okay, yes. Let's go through it first, guys. Come on, Jewel. Come on. I'm not torturing her, guys. She eats for free. She eats for free. All right. So your cervical spine, okay? The higher up starts at C1. So if the pain is in the back of the head, it's usually a C1. You don't have the C1 nerve root compression. The C1 nerve root comes up over C1. So you never have a C1 nerve root compression unless you have like a fracture of the C1 ring or something like that. But usually C1, you don't have a nerve root compression. C2, neither. You don't have a nerve root compression at that level. Usually starts at about C3, C4, and usually don't herniate that high up. But you can have spondylosis or spondylolisthesis. You can also have those at that level. So you can have some nerve root impingement up there, okay? So you're gonna start higher, C1, C2, come down into the neck, okay? Then C3 and C4 is in the neck. C5 is in the shoulder and deltoid, okay? C6, you can have some deltoid pain and bicep, okay? C7, you will have tricep, okay? And C8 can go down into their forearm, okay? C6 will be your thumb. C7, C5 and C6 will be your thumb. Yeah, relax. Okay. Relax. All right. You go into your thumb. You get C5, the thumb and part of this. C6, part of the index finger and part of the middle finger. C7, the rest of the middle finger and part of the ring finger. C8, the last part of the ring finger and the pinky fingers. Okay? So when we're assessing the cervical spine, we're going to start with deltoid. You're going to tell the patient to put both of their arms up. Okay? And you're going to tell them, don't let me pull you down. Don't let me push you down. Keep them up, don't let me push you down. Okay? That's checking the deltoid. Bicep, you're going to have them pull their arm out. You're going to anchor the shoulder so you don't pull the shoulder out of the hinge. And you're going to say, don't let me pull you down. Okay? And you're going to do that on both sides. Don't let me pull you down. Okay? She's a little weak. Now, for the tricep, I'm going to say push against me. Same one here, push against me. You can also do the tricep, put your arms up. You can do bicep, don't let me pull you out. That's also checking bicep. And tricep, push me away. Okay, that's also checking tricep. Okay? The hand intrinsic, you can do hand flexion. Keep your arm like this, don't let me pull it down. Okay? That's C7, C8, push down. Push down. That's T1. Grab a hold of my fingers. Squeeze. Don't let me pull it out. That's also C8, T1. Okay? Put your fingers across. Don't let me push them together. C8, finger flexors. Put your hands like this. Don't let me pull it out. That will be C8. Okay? All right, guys? So, with this patient, we already know that she has a C6 injury. Bicep is what's the muscle affected, and it's on the right. Any other question? Any questions with that one, guys? And also the bicep reflex. I see some of you guys do it. Relax. Get the patient to relax. Strike your own finger. And all you need to see is contraction of the bicep muscle, okay? And that's C6. Tricep.
Can you move the camera down just a little bit, please? Thanks.
I'm sorry?
Can you move the camera
Say that
down
again,
just a
Laura?
little? Can you move the camera down just a little bit? Yeah,
You can see
perfect.
me now?
Thanks. Yeah.
All right, so let me do that again. Strike your finger, and you should just see, relax. And you should just see her muscle contracts, okay? You strike your finger. Tricep, just relax. You're gonna locate the tricep tendon, and that's what you're gonna strike, the tricep tendon, and you should see shortening of the tricep muscle. And the brachioradialis, she has all these ridiculous rubber things on her hand. I don't know why. You're gonna find the brachioradialis tendon. Relax. Lay their hand rest on yours so they can relax. She thinks I'm gonna beat her up, so she's not relaxing. Then you're gonna strike. No, I gotta get a reflex. Relax for real. Lay your hand on mine. There you go. And then you should see the fingers contract there. Do you find the brachioradialis tendon? I don't have a great patient. And it should relax. Their hand should come like this. Not a great patient. Any questions, guys? Guys? Nobody?
No, everyone's just kind of giving an LOL. Haha.
Oh. Poor turn, Julie. Bye.
Thank you, Julie.
Thank you, Julie.
She eats for free. All right.
It's tough.
All right, guys. So let's go. I think we already said this one was C6. All right. 36-year-old female presents to your clinic with complaints of intractable pain in her cervical area that radiates down her right arm. She reports the pain is in the lower part of her neck, radiates to the posterior aspect of her right arm into her hand with numbness of the last 2 fingers on that hand. The pain has been present for the last few months. She believes that it has gotten worse over the last 3 days. She describes it as a shooting, sometimes achy. Patient also has had trouble buttoning her blouse, picking up items, holding a coffee cup. She's A&O ×4, CNS exam is intact, her motor and reflex exam is below. She has finger flexor weakness on the left. This is kind of tricky because in this case, she could have some tricep weakness also. So you may see some tricep weakness with patients like this, okay? Brachioradialis tendon is 0. Which nerve root is being compressed? Laura? Let me open Dr. Buha took a break.
No, I'm here. It's C8.
Yes. C8. Anybody said anything different? Anybody confused why it's C8? No? Okay, great. All right. Case number 19. We're almost done, Laura, right?
Yes, there are 20 cases.
Okay,
Almost
good.
there.
All right. Tom is a 35-year-old
wait, sorry, hold on before we start. Sorry, Dr. Morton. Question. What about the lower neck pain? I think from the last question.
Well, usually they start with neck pain and then it shoots down. Okay? So that's the pain with the radiculopathy.
Okay.
Okay.
So is
usually
only C8 involved or is anything else involved?
Judging from the exam, it's only C8, there's nerve roots that's being compressed.
Okay. Thank you.
Right. And then again, patients will come in with back pain. They will always come in with back pain and they'll say, my back hurts, but they'll say it radiates down my lower back. It goes all the way down into my leg and then it goes to the side of my foot. Then you know that's L5. Just the same with the cervical. They'll say it starts in my neck and radiate down the arm, okay, all the way down to my fingers. Then you know that's the C8, okay? So it's neck pain with radiculopathy. That means that the nerve root is being impinged on.
Okay, there's a couple questions. So can this be, can it cause dizziness?
Usually it doesn't. You can have a spinal stenosis that can cause dizziness. And stenosis is narrowing of the spinal canal, so it can cause compression of the spinal cord, and that itself can cause dizziness. The spinal cord compression will cause you dizziness. The nerve root compressions, not so much.
Okay, and then also could it be from a tumor?
Of course, you can have a tumor that's intradural, extramedullary, that's pushing up against the nerve root, that can cause that. You can have intramedullary tumors. Extramedullary means that it's not in the spinal cord. Intramedullary means that it is in the spinal cord and expands the spinal cord. Usually with those patients though, because it's an intrinsic injury to the spinal cord, you're gonna see more upper motor neuron. So you will not see brachioradialis tendon reflex absent. You will see hyperreflexia because it will involve the spinal cord. Does that make sense?
Yes.
So you want to look, there's an upper motor neuron versus lower motor neuron. If it's a nerve root and you have a 0 at brachioradialis, you know that's a peripheral thing. That's a nerve root compression. But if I do deep tendon reflex and they're about slapping me in the face, that means that they're hyperreflexia. That means that there's some spinal cord involvement. They can have the same spread of pain with spinal cord involvement, if that's what they're asking.
Okay.
Let me know if that clarifies anything.
Yeah, and then a couple questions. So we focus on where the pain radiates.
And the other symptoms associated with it.
Okay.
When I
and then-
see a patient that comes in with back pain, I'm gonna ask them, when did the pain start? I'm gonna ask them, where is the pain? Does it radiate to the legs? If it radiates to the legs, where in the legs is the pain? So I always ask them, is it anterior or posterior? Does it go past the knee? Does it go into the foot? Does it go into the toes? If it's in the neck pain, does it go into the hand? Does it stop at a certain part of the hand? Is it in the bicep? Is it a tricep? Does it stop at the deltoid? And you'll be surprised. You'll see patients with a pain pattern, and it's like, oh my God, this is textbook.
Okay. And then they ask about sciatica.
Sciatica is what usually people talk about when they talk about their irritation of the S1 nerve root. That's the sciatica pain. But if you have a some kind of impingement that's touching on the sciatica pain, the sciatica nerve root, you can call it sciatica. But basically, what it is a S1 nerve root problem.
Perfect. And then, oh no, someone has an answer for case 19, but I know we're kind of still starting on it, so I won't share it yet.
No,
Everyone
please.
can see it, but okay.
Okay. So 19, Tom is a 35-year-old male with past medical history of diabetes, type 1, hypertension, mild, I don't know what I mean. I don't know what I mean by that. Anyways, presents with evaluation of constipation. He reports an ability to defecate for the past 5 days, and as such, he reports loss of appetite and nausea. He reports that he saw his PCP 3 days ago, who prescribed him several laxatives, but he has had no relief. He reports that he has not voided since waking up this morning. It is now 4 p.m. I'm sorry. And he has no urine output. He denies pain. He denies any numbness, as he does have some numbness in his legs due to having neuropathy. Okay. How would you work up Tom?
Aquinas syndrome, I think.
How do you work up Tom? Can we start with the workup?
Oh, sorry.
How do you work him up? I know everybody's anxious to give the diagnosis. Dr. Abuha tells me you guys already have it. So,
Yeah, and they're saying CT, abdominal CT, and MRI.
okay. What would we do the abdominal CT? What would we do first? What would you
CT.
do first?
Rule
Out any abdominal obstruction.
CT.
Okay, you can do that.